prostatectomy. اتفضل.
Who is the one who did the brushing of bladder stone and transplantation resection just half an hour ago?
As well. So, good afternoon. You're welcome in Mansoura. I'll try to keep concise as much as I can. I know it's a bit late. You are asleep. So today we are going to talk about BPH new technology. And in my talk, I'm trying to cover what is the gold standard treatment for BPH. Do we need a new technology? What are the new technologies available? And does it work in a developing country like ours? So what is the gold standard? So gold standard is defined as the monetary standard. Okay. The monetary standard under which the basic unit of currency is equal in value and exchangeable for a specific amount of gold. And in surgical terminology, it is a test of value of a procedure that is considered superior under different circumstances and widely available and accessible to the majority of the population being served. We're looking for BPH. For years, the gold standard is transurethral resection of the prostate. It's almost always referred as being a gold standard. On which basis is it based on the randomized controlled trial? Have we ever compared TURP to a previous gold standard? No. Only test of time. For 50 years, TURP is the test of time, and it is the gold standard everywhere in the world. However, currently, we do have a challenge for TURP, for transurethral resection of the prostate. So if we ask ourselves, does TURP fit all the time? I don't think so. Because in a patient with bleeding tendons, oral anticoagulation independently impacts the TURP outcome, and it's significantly associated with longer hospital stay, higher rate of bleeding, blood transfusion, late hematuria, and thromboembolic events. What else? In naturally anticoagulated patients. Here in Egypt, we have a lot of naturally anticoagulated patients. Patients with chronic liver disease. In our locality, we have high prevalence of hepatitis C virus, high morbidity and mortality from chronic liver disease, cirrhosis, and hepatocellular carcinoma, ending up by different grades of liver cell failure and uncorrectable coagulopathy. So you cannot treat this patient with TURP, with regular TURP. When we look for the outcome of TURP as regards the prostate size, with this prospective multi-center evaluation of almost 11,000 patients from Germany, when they start to treat this patient with regular transurethral resection of the prostate, if they resect more than 60 grams, there is significant increase in the perioperative morbidity and mortality. Blood transfusion rate reaches almost 10%, and surgical revision is almost 10%. So it's not the best for large-sized prostate. Randomized controlled trials of transvesical prostatectomy, open prostatectomy against TURP for large-sized prostate showed that more tissue was removed with open prostatectomy and better functional outcomes as well with open prostatectomy at 12 months in terms of symptom score and flow rate. This is our study showing the perioperative morbidity of almost 43% for patients treated with open prostatectomy and up to 1% mortality after open prostatectomy. And when we looked to this nationwide study from Austria and long-term morbidity analysis of almost 23,000 cases of TURP and open prostatectomy, the overall incidence of secondary procedure, in other words, really do for TURP or urostomy or bladder neck incision, is almost 15% after TURP and 10% after open prostatectomy. In other words, TURP is fine procedure. As long as we remain within our limits, we treated an index patient with an average size prostate, no coagulopathy. But what about the global pictures throughout the world? Many surgeons referred to and still insisted that other technologies, laser, all other technologies are superfluous for surgical management of BPH in a developing country. So again, the question, do we need a new technology? Yes. The patient coming to us as a surgeon to treat is a change. Long-term BPH medical treatment ended up by larger process coming for surgery, so more morbidity, and more older patients are coming for surgery. So they are more comorbid, more anticoagulated, more pacemakers, and frequently coming with indwelling catheters for urinary retention. So the new technology is coming. Why? Meaning less invasive, low morbidity, shorter hospital stay or day surgery, shorter caster time or no caster at all, fit for bleeding tendency. There is no size limitation, and that is cost effective. So what are the new technologies? The new technology come in any resource which work in a physiological setting as arrogant to avoid working with glycine and the risk of TUR syndrome. A new technique associated with less bleeding and more tissue removal, so we can treat whatever size of prostate. So this image is very useful for understanding the physics of lasers that we are using. So this is the electromagnetic spectrum, and here what's called the visible light from 400 to 700, and this is the ultraviolet spectrum, and this is the infrared spectrum. We have our lasers lying with their wavelengths throughout this spectrum. And how does it work with us? So we have two famous lasers, which is the Greenlight laser, the KTP laser. Its wavelength is 572 nanometer, and with this wavelength, it's absorbed mostly by oxyhemoglobin. And the other kind of laser, which is holmium laser, it lies here in the infrared spectrum, and with this characteristic wavelength, it's absorbed mostly in water, as we have described during our work today. What is the other energy source? It's the plasma. It's an electrosurgical technology, depends on conversion of the standard electricity by a special generator to cut and coagulate tissue. This orange color is the plasma. It used to be generated by the bipolar electrosurgical units. And what are the techniques? We are going to tackle the prostate adenoma about whatever kind of technique. We can use vaporization of the prostate adenoma. We can resect as we did today. We can vaporisect, vaporiculate, and we can do complete inoculation to peel the adenoma from the surgical capsule completely. So, the godfather of inoculation is what's called holmium laser inoculation of the prostate, or HOLEP. I will go in 30 seconds throughout this video showing the principle of holmium laser inoculation of the prostate. We are using the holmium laser energy to cut through the prostate tissue and dissect the adenoma, peeling it off the surgical capsule. So we are using the same piece of equipment that you have seen. We cut through the prostate tissue to identify the surgical capsule, and then we use a blunt movement to identify the natural plane between the surgical capsule and the adenoma. This is exactly what you used to do while doing an open prostatectomy. Instead of using your finger to dissect, to go between the adenoma and surgical capsule, you use the tip of the scoop, and you are assisted by being under vision and then using the laser to cut and coagulate simultaneously. You are going to peel off the adenoma completely from the surgical capsule, pushing it toward the bladder, and then you will be in need to retrieve the prostate tissue using what's called tissue morcellator. So again, finally we push the adenoma to the bladder, and we will suck the tissue out using what's called tissue morcellator. Let us look about the results or the outcome of HOLEP as regards the efficacy, safety, and durability. So the data have shown that there is equivalent symptom score reduction to both open prostatectomy and transurethral resection of the prostate following HOLEP. And furthermore, the hemodynamic relief of obstruction with HOLEP is superior, or at least equivalent to TUR and open prostatectomy. And based on the resection speed, HOLEP is faster than TUR and similar to open prostatectomy. And percent reduction of PSA and prostate volume following HOLEP have been reported to be as high as almost 80 and 86% respectively. And this is what we can obtain after 4 months by transrectal ultrasound. This is a very nice prostatic fossa following HOLEP, allowing free flow of urine. And the efficacy and feasibility of HOLEP has been also proven for recurrent or regrown prostatic obstructing adenoma after previous transurethral prostate surgery with similar outcome. It's safe, being done in different sizes of prostate, so it is a size-independent procedure. It's safe in elderly patient above the age of 80. It's safe in patients with ongoing anticoagulation or antiplatelet therapy. And blood transfusion rate has been reported to be less than 1% following HOLEP. We are using surgical saline, so there is no risk of TUR syndrome. As regards the durability or the need for reoperation, the anti-incontinence surgery following HOLEP is less than 1%. And in a study of almost 1,200 patients with a median follow-up of 7 years, following HOLEP, the freedom from reoperation was 97 at 5 years and 95 at 10 years. So, what are the other techniques? Tissue vaporization. Again, the best laser for tissue vaporization, or the actual laser that we do have here, and we are using it for prostate vaporization, is the Greenlight laser. So, we have this 57-year-old male. He had an inguinal visceral catheter for acute urinary retention with failed trial avoiding trial 4 times on medical treatment. He has a liver cirrhosis with prostatic concentration 44%, platelet count of 65,000, and his prostate 65 grams. If you do have only transfusion section of the prostate, the procedure will be quite morbid for such patient. And we often end up by asking him to have the catheter in the wedding. However, we can treat him with a Greenlight laser photoselective vaporization of the prostate. The main criteria of such type of laser that it is absorbed by the oxyhemoglobin, so it has a high affinity to the tissue which is rich in blood, which is the prostate. So by application of this light laser energy, it will end up by conversion of the prostate tissue into bubbles, vaporizing the prostate tissue. Regularly, when we start whatever kind of transurethral prostatectomy, we start by creation of a working